So good morning and welcome to today's COHTAC Share and Learn, all about medical dental integration during pregnancy. We are thrilled to have you here, and like I said, we have a really exciting lineup. So just a few housekeeping items. This meeting is being recorded and we will post it on our COHTAC website and our YouTube, and we'll send a follow-up email to everyone who registered for today's event so they can watch it in their own time if needed, or y'all can come back and watch it again. If you have questions, please put them in the meeting chat box, and also feel free to comment, share resources, whatever in the chat box. We really like to make this engaging and interactive. And then toward the end, we will be sharing a link to a Qualtrics survey for your feedback. As always, we really appreciate your feedback to help us make these even better. So I wanted to just take a minute to share who we are and what we're doing here this morning. So some of you might be new or not familiar with our group, which is called COHTAC. That stands for the California Oral Health Technical Assistance Center. We are funded by the State Office of Oral Health to provide technical assistance to local oral health programs, or LOHPs. And we do this in a number of ways. We do webinars like today. We host in-person meetings. We do group technical assistance. We have this website down here, oral health support at ucsf.edu. It's full of resources. And then we also do one-on-one support through our email or meetings or site visits. We have a large team, as you can see. A lot of us work only some time on the project, and there's a mixture of dentists, dental public health experts, and so we are all here to help you, and we're excited to do so. So if you need anything, feel free to email us at that inbox right there, oral support at ucsf.edu. All right, on to today's agenda. So we are super excited to be hosting folks from La Clínica de la Raza to talk to us about what they've been doing around medical dental integration in pregnancy. I'm also excited to say we have Jay Kumar and Lisa Behrens to present at the onset as well. So I'm going to do short introductions and then I'll pass it off to Dr. Kumar. First, you're going to hear from the State California Dental Director, Jay Kumar, to tell us why the Office of Oral Health wanted us to dedicate a webinar to this topic. And then it's going to be followed by a member of our COHTAC team and a professor at the UCSF School of Dentistry, Lisa Behrens, to tell you more about pregnancy and oral health. But like I said, today's main presenters are Anastasia Coutinho and Monica McVeigh-Pearson from La Clínica de la Raza, which is a federally qualified health center that has been integrating oral health into their prenatal care as part of the Consortium for Oral Health Systems Integration and Improvement. We'll be hearing from both the medical and the dental sides of this work, as Anna is a full scope family physician and Monica is a dentist and the associate dental director at the Fruitvale Dental Clinic. So you can read more about our speakers at a link that I'm dropping into the chat box. But now it is my pleasure to stop screen sharing and send it to Dr. Kumar.
Okay. Good morning, everyone. I am really happy to be here today to share with you some data from MIHA, our Maternal Infant Assessment Survey, and talk about the importance of oral health during pregnancy. So there are three reasons why pregnant women should seek dental care and improve their oral health, and also to maintain good oral health by engaging in healthy habits, because some women experience inflammation of the gum, and also many women may not have dental care insurance coverage before becoming pregnant, and they may have other conditions like wisdom teeth impaction or large cavities, and they have to take care of those. And the second reason is because infants acquire cavity-causing bacteria from caregivers. And the third is there are some very good observational studies showing association between periodontal disease and adverse pregnancy outcomes. However, I have to share the information that the clinical trials, when they treated pregnant women, didn't improve pregnancy outcomes. So there is a need. There is very good data suggesting the association. That means we have to intervene even before pregnancy to make an impact on improving the pregnancy outcomes. So New York State was the first state to issue pregnancy guidelines. We worked on it in New York, starting in 2003, about 20 years ago. And then California issued the guidelines in 2010, professional guidelines for improving oral health. And then this is the Health Resources Services Administration, MCH Bureau, issued their national guidelines consensus document in 2012. And we published a collection of articles in the California Dental Association Journal last year. So you may want to, this is available online, so you can look it up. So what has been done to improve the oral health of pregnant women nationally and also at the state level? We have promoted professional guidelines. Almost all professional organizations, including the American College of Obstetrics and Gynecology, they have endorsed the guidelines. And expanding insurance coverage. I'm sure you're all well aware about dental insurance coverage in general, postpartum. Now in California, it's available for Medicaid enrolled beneficiaries for another year. So there is time for dental treatment to be completed even after pregnancy. And then tracking maternal child health block grant Title V performance measure. So there is a performance measure in this grant that is given to states by the federal government, and promote medical dental integration. And this is where we have made a whole lot of improvement over the years. Dentistry is still separate and distinct from rest of the body when it comes to insurance coverage, electronic dental record systems, when it comes to training. So we need to do a lot of work to integrate dental and medical. So this is one of the recommendations coming out of the Surgeon General's report. And not the surgeon, and it came out of the Surgeon General's report in 2000, and the most recently issued Oral Health America report that came out in 2021. And increasing oral health literacy. And if you look at the data in California, comparing 2012 to 2019-20, we don't see a whole lot of change in dental visit rates. And when you look at by race, ethnicity, income, and education, we see profound disparities. For example, when you look at Medicaid versus privately insured pregnant population, you see a difference about 19 percentage points. So the reason, we ask in our MIHA survey about reasons for not visiting a dentist. And you can see the number one reason is didn't need to go, too busy, then didn't think it was safe to go during pregnancy, cost too much, didn't have dental insurance, and then don't like going because of fear of dentistry. So we have a lot of work to do and in this area. And we have seen improvement when medical dental integration projects are implemented at the county level. So this is data from California comparing it to Sonoma County. As you can see, Sonoma implemented a perinatal oral health quality improvement project, mostly in FQHCs. And you can see difference in utilization when compared to California, especially among the Medicaid beneficiaries. So Sonoma is one county where you can see the utilization rate among Medicaid enrollees is better compared to the privately insured. So this is a success story. So when it is integrated, we can make big improvements. So thank you. So I'm sure there are other speakers who will cover in greater details about medical dental integration. Thank you.
Thanks, Dr. Kumar. Now I'm going to share my screen and invite Lisa to present.
Hello, everyone. Good morning. Thank you, Aubrey. Thank you, Dr. Kumar. So I'm going to go just a little bit deeper in terms of the science and the biology and of why oral health is important during pregnancy. It's a good thing that without having conferred with Dr. Kumar, we had the same three reasons why it's important. And so if we could go to the next slide, please. So why oral health during pregnancy? Why maternal oral health? Well, this is just a brief review. You just heard Dr. Kumar say, but it's really important to promote oral health during pregnancy. And number one, it's that pregnancy confers this increased vulnerability to oral health problems such as bleeding and tender gums. Any oral health problems that you have prior to pregnancy can become exacerbated during pregnancy. And if you just click one more time. Yeah, so you have inflamed gums, your teeth are more mobile, and there's tooth erosion. So the next slide will show you some clinical, there you go. Here's a picture of what we call pregnancy gingivitis. And it's quite common among pregnant women. We'll hear prevalences as high as 70, 80%. These gums are very tender and they bleed easily. And it's the gums' response to pregnancy hormones. And it's largely preventable if there's good oral hygiene that's maintained throughout pregnancy. The picture on the right shows you what's called a pyogenic granuloma, and that occurs in about 10% of pregnant women. Both of these conditions are benign and they resolve after pregnancy, though the granulomas may sometimes be excised if they cause discomfort. Okay, the next issue that we see sometimes during pregnancy is erosion of the teeth. And so the oral cavity is exposed more often to gastric acid that can erode the dental enamel on that lingual or the inner side. Morning sickness is a common cause early in pregnancy. Later, lax esophageal sphincter and upward pressure from the gravid uterus can cause or exacerbate acid reflux. So rinsing the mouth with a teaspoon of baking soda and a cup of water after vomiting, that can help neutralize the acid. And that's actually part of the New York State guidelines. Okay, next slide. So the second reason is this carriogenic bacterial transmission to the infants. So, human beings acquire the bacteria somewhere, and the most common source is, if you go to the next slide, is the mother or the caregiver. And so this transmission from mother or caregiver to the infant has been very well documented. And it's transmitted through saliva, and mothers with high levels of the carriogenic bacteria, they're more likely to transfer these bacteria to their infants. Okay, so the next slide, there is opportunity then to educate pregnant women and counsel them to modify their own behaviors. And the first thing is around how they can decrease their own levels of bacteria. And you can do that through your diet, oral hygiene, home care, and your carry status. So if you have untreated decay, that's correlated to higher levels of bacteria. Number two, we can advise and guide and educate moms on avoiding common parenting behaviors such as sharing a spoon or bites of food, things that will pass on carriogenic bacteria, their saliva sharing bacteria essentially, or licking a pacifier clean after it drops to the floor before giving it back to their baby. And so it's important to counsel on modifying these behaviors, and that can decrease the child's risk for developing early childhood caries, which brings me to the next slide that many of you already know and have heard this, but dental caries is the most common chronic disease in children. And it affects 21% of US children in this 2 to 5 year old age group. That's the data that's available to us from NHANES data, the most recent. And the third reason, next slide down there, is you'll see I have a little dotted line, and that's the periodontal disease association with adverse pregnancy outcomes. And the next slide, or the one after that, is where we are in terms of the state of the research evidence. And like Dr. Kumar said, observational studies are mixed, but that's where you see a lot of the positive associations. There are some observational studies that have shown no association, but what you'll find if you look closer is that the ones that had a positive association, they're largely conducted in the US with large proportions of African-American patients. And the ones with no association are internationally conducted studies and somewhat larger. And then the experimental studies, especially the randomized controlled trials, many of them did not show a causal link between periodontal disease and adverse pregnancy outcomes. So we cannot say that, controlling your gingival health will decrease your pregnancy outcomes. We can't say that because the clinical trials did not show that outcome. However, what it did demonstrate was that dental treatment in cleaning and scaling and root planing care is safe during pregnancy. A little bit next slide about the proposed mechanism of how this can happen is that there's two ways. There's a direct effect of periodontal infection, and there's an indirect effect. And the direct effect is from the bacteria and the toxins can then travel to the fetus in utero. And then the indirect is that it's the host response to the bacteria. So the inflammation that happens in the oral cavity can then send the factors, inflammatory factors through the body, and then transferred to the fetus in utero, and that can induce preterm low birth weight and other adverse outcomes. Okay, and so despite the benefits of good oral health during pregnancy and why we promote it as being important to do this during pregnancy, this is the MIHA data of only 40% reported visiting the dentist during pregnancy. And this is just 1 year more recent. Dr. Kumar had, I think, up to 2019, 2020. This is 2020, 2021. So obviously during COVID, and it went down 3 percentage points. I would have thought that it would go down further because of COVID, but here we are at 40%. Definitely has not improved over that long period of time that he showed. However, you'll see that the prenatal visit rates, I think that went down a little bit, but 89% received early prenatal care, and that's defined as during the first trimester, or the first, second, or third month of pregnancy. 89%. And so from this, we know that obstetricians, family physicians, nurses, nurse midwives, other prenatal care providers and staff, they're often the first and perhaps the only professionals to consult with expectant parents to discuss how to prepare for a healthy pregnancy. Okay, and then the next slide, it was around the late 2000s where there was a lot more attention given to this, and also recognizing that women or pregnant people were having difficulty or were not utilizing dental care for a number of reasons. And so a lot of organizations, and this is the Institute of Medicine report in 2011, now they're the National Academy of Medicine, and they published this on the improving access and oral health care for vulnerable and underserved populations, saying that pregnant women were one of those vulnerable groups. And they say non-dental healthcare professionals need to take a role in oral healthcare. And then the next slide shows you these various guidelines that came out in, like Dr. Kumar said, New York, and then California's in 2010, and there are some other states. And then at the national level, that's this document here, the Maternal and Child Health Bureau. I think that was in 2012. And then ACOG came out with their committee opinion in 2013 and endorsed these guidelines. And if you go to the next slide, to summarize the clinical guidelines for perinatal health, oral health for the prenatal care provider side, is to assess and refer, promote healthy oral hygiene and dietary practices, and to really assure their patient that dental care is important and that it is safe. And then also to include anticipatory guidance for the infant, so regarding cleaning and feeding and saliva sharing behaviors. And then also provide the assistance in referring to dental provider, and also assistance in insurance. So that brings me to the next part of the webinar. As you will hear a very, very nice collaborative partnership that you'll hear from La Clinica that has really taken the recommendations of these guidelines and has resulted in some nice outcomes. So I will turn it back over to Aubrey.
Straight over to La Clinica, actually.
Okay.
So Dr. McVeigh-Pearson and Dr. Coutinho. Thank you, Lisa.
Okay, very good. I assume you can hear and see me. Okay. Very good. Good morning, everybody. So this morning, myself and my colleague, Anna, Dr. Coutinho, are going to present about the medical dental collaboration that we're doing at one of our La Clinica sites that is co-located medical dental. La Clinica is a large community health center, FQHC, in the East Bay, San Francisco area. We operate in Contra Costa, Alameda, and Solano counties. We have about 36 sites, including medical, dental, behavioral health, lab, pharmacy, school-based. And so this collaborative is being run at our clinic in Concord, which is co-located medical and dental. La Clinica has been around for about 52 years. Myself, I've been a dentist at La Clinica for 17 years. I'm the director of one of our dental clinics for 15 years. And for about 3 years, I am the deputy dental director for the dental department. With that, and I'll say that we see pregnant patients all the time in dental throughout my career here. With that, I'll pass it over to Anna for her to introduce herself.
Hi, my name is Anna Coutinho. I am a family physician and at one of our sites in Concord, and provide full scope family medicine. So see pregnant people, kids, elderly people, and have been working with Dr. McVeigh-Pearson and our team in this integration project focusing on prenatal patients. I've been there for about 5 years. So we'll just pass to the next slide. Before we go through our presentation, we just wanted to get an idea of who is in the audience. And so we're gonna launch a poll, 2 polls about what role you have in your organization and how you would kind of describe your current integration efforts, just so that we know who we're talking to. And Aubrey, whenever you feel like there's enough time, you can show us the results. Perfect. So it looks like most people here are public health professionals, program managers, with some health educators, and we have some dentists in the audience, and that many people are kind of in the newer side of their integration efforts. And for those people who have been doing it a while and are experts, hopefully we can learn from your wisdom and experience too. I'm going to pass it to Dr. McVeigh to kind of describe a little bit of the consortium that we've been a part of, and then we'll get to our results.
Perfect. So this project is part of this integrating oral health care and primary care learning collaborative, which is being run in conjunction with HRSA, Georgetown University's National Maternal and sorry, it's so tiny on the screen. It's hard to see their name, and I always get it mixed up. But they're National Maternal and Child Oral Health Resource Center. So this is run in conjunction with Georgetown University and NOAA, which is the National Network for Oral Health Access. I say that NOAA is a little bit like the American Dental Association for community health centers. So if any of the dentists involved in community health are not aware of NOAA, it's a great resource. And so it's being run in 11 states nationally, and La Clinica Concord is the location for California. We do have, as you saw, members of the California Office of Oral Health on the line, and so they're very eager to see our results and see our success. It is our intention, basically we're working on formulating the system and ironing out the wrinkles. And then in the new year, our plan is to roll this out across our organization. And I know that the county and the state are thinking of planning to roll it out also across the county and the state. So all eyes on us. So every state and every site that's doing this is doing it a little bit differently. And so I know one of the questions that came in the pre-presentation poll or survey was if other states are doing it the same and what their challenges are. And, you know, there's 11 groups working on this, and everybody's results and challenges are a little bit different, and their approach is certainly a little bit different. So we're just one case study, and we're going to be sharing our experience thus far. We've been participating in this for about a year, and officially this project wraps up, this learning collaborative wraps up at the end of December, but we're going to continue on, as I say, to roll it out. We can go on to the next slide, and Anna, you can jump in anytime you feel I forgot something. So then this project consists of 5 domains. One is risk assessment. And so the risk assessment is the patient receiving an assessment of their risk for dental diseases in their OBGYN primary care office by the OBGYN primary care team. So with La Clinica, our risk assessment consists of a series of questions that is gone over with the patients when they have their intake appointment as a pregnant patient. Okay, we'll get on to the questions more in the next slide. The oral health evaluation is the PCP team, the medical provider, actually looking into the patient's mouth and doing a cursory exam of what they find there. The preventative intervention that we came upon is fluoride varnish application. There's different preventative interventions that one could maybe do, but you need to have something that is measurable, that you can check for a specific benefit to it. So we discussed different things like providing the patient xylitol, but then how do you know if they used the xylitol? How do you measure how much they used the xylitol? How do you measure the effect? So fluoride application may not be the best preventative intervention, and it's certainly not the only one, but after much going around is the one that most of the team settled upon. Then there's communication and education, which is again at the medical office, education being given to the patient and communication about the importance and the safety of dental care. And the interprofessional collaborative practice is the referral of the patients from medical to dental. There's two components to that domain. One is the routine referral and another is the urgent referral if they've determined that there's a more urgent issue. And then our team has certainly stepped up the interprofessional collaboration in the sense of having, for example, the dental team go over a couple of times to the medical department and doing sort of little in-services during their staff meetings. Certainly, I think the medical department knows the dental team better and the dental team now knows the medical department better as a result of this project. I believe we can go on to the next slide and we'll be talking a little bit more about each of these aspects in detail as we go through. So Anna can take this slide.
Yeah. So just as a overview for people who aren't aware of how prenatal care is delivered, California has this CPSP program that you'll see on the slide, which stands for California Perinatal Service Program. And that allows community health center to provide certain wraparound services and get paid for them. And so as part of that program, people get an orientation to the clinic to pregnancy care in which a community health worker, a health educator, in our clinic, a supervisor, discusses just how people will receive prenatal care, and then does a little bit of education around specific topics. As part of CPSP, people also get hooked up with nutrition consults that can be done every trimester, separately health education that can be done every trimester in postpartum, as well as a social work visit, again, every trimester in postpartum. And so that's a way for community health centers to provide additional services at a billable rate and just provides patients with the opportunity to get a little bit more education at different points throughout pregnancy and postpartum period. And so for our kind of risk assessment, after discussing different options between the dental and medical teams, we narrowed down a series of questions that we'll go through. And our goal was to have something that wasn't too lengthy for anybody to provide or for patients to answer, but was able to triage patients into urgent and non-urgent patients so that we can appropriately direct them to our dental clinic. So as we go through them, just think that there's many other questions that you might feel compelled to ask, but thinking about capacity in terms of just how much time we each have with the patient is important. And then secondly, the big piece that we thought about was who is going to be doing this risk assessment. We could do it with a health educator, with the actual prenatal care provider, and we're all kind of at capacity in terms of the things that we need to do during each appointment. That we chose to incorporate these risk assessment questions during the CPSP orientation appointment, which is done with our prenatal supervisor, just because they have a little bit of a longer appointment. It's usually about 45 minutes to an hour. And then the patient is kind of set up in that kind of discussion mode. And it also gives the opportunity, excuse me, for that prenatal supervisor to provide a little bit of education after the risk assessment that we'll talk about on another slide. But as we go through these questions, and Aubrey will take us through them, we ask if patients currently have a dentist, so we know whether to direct them to our La Clinica dental site. in our building versus just giving them additional information about why they should see their own dentist. We ask if patients have had their teeth cleaned in the last 12 months, because if they've had them cleaned, more likely their teeth hopefully will be in better shape. And then just for insurance coverage reasons. We ask if people would like to be referred to our La Clinica dental team. And if no, we talk about, can we share some information with you about the importance of oral health in pregnancy? I think going back to Dr. Kumar's slides, the top reason that people don't see a dentist is that they don't think that they need to. And so we try and use this as an opportunity to provide a little bit of education about why they should be seeing a dentist if they haven't. And then we do ask some questions about specific symptoms or signs that might lead us to think that the patient would need a more urgent referral than a routine referral. And we chose swollen or bleeding gums, toothache or mouth pain, problems eating or chewing, and then a general question for problems in your mouth that people can expand upon. And then finally, we asked just about questions or concerns about oral health care or getting oral health care while people are pregnant. I think big things that come up are, fear around seeing the dentist, knowing whether things are safe, like x-rays or cleanings are safe in pregnancy. And so Liz is able to respond to those questions. And then again, just if anybody answers yes to the 4 trigger questions in number 4, we lead towards an urgent dental referral rather than a routine. On the next slide, we talked a little bit about this, but this is part of the beginning piece of our referral. We ask the questions of the risk assessment to determine whether we're going to place a referral and which type of referral we're going to place. And our prenatal supervisor probably does 99% of those referrals. If somebody no-shows their CPSP orientation appointment or declines at the beginning, our flow is that the provider at their first prenatal visit or subsequently, if they bring up concerns, symptoms within the mouth, that the provider can also refer depending on need. And we use Epic as our EHR, and we place a referral that we've created that will go through the steps into that so that the dental team can access the referrals that we've placed. And so this is just what the dental, excuse me, this is just what the dental referral looks like in Epic. I think it's important to know that we don't have an integrated EHR. Dental uses Dentrix, which is separate. And so we did spend time examining how we could communicate and create closed loop referrals, which was one of the questions that someone asked in the pre-survey. So we'll be going through that. We make sure that the order just says referral to dental, but the most important part is the second circle where the priority is listed. And there's routine versus urgent so that our dental team knows how quickly to book those patients for an appointment. And then in the far left circle, we do indicate a prenatal reason. And so that separates our prenatal pregnant patients from kind of other people who might be getting dental referrals. And depending on what you need in your clinical site, there's a bunch of different options for kids, diabetics, etc. Next slide. And so Dr. McBain will talk about kind of on the dental side, what happens.
Right. So our front desk administrative staff are able to go into the Epic work queue and review those patients that have been referred and see if it's an urgent or a routine referral. For the urgent referrals, we make them our top priority to reach out to them, to try to get them in, to try to follow up with them. The first visit with dental following the pandemic, if a patient has not been seen in dental or has not been seen since the pandemic started, most of our first contact with dental is a telehealth appointment. In the telehealth appointment, we screen them for urgent problems. And if they don't have problems, if they don't express problems, then instead we go over some of the basic preventative information that sometimes we don't have a lot of time to do in the dental office, like what kind of water do they drink, how many times do they snack in a day, and sort of healthy diet and oral hygiene information. We're pretty good in the dental office about going over those things with kids and kids' parents, but outside of hygiene visits, it's not something that we always spend enough time discussing with the adult patients. And so it's a good opportunity if they don't have a concern to talk about and be triaged for in telehealth to talk about that. And then if they do have an urgent problem, they can bypass the telehealth and just get an in-office visit. If during the telehealth, it's identified that they have some kind of a urgent concern or a concern, we offer them to have a office visit to come in and just take a look at that issue while they're waiting for the exam appointment. For our non-pregnant adults, the exam appointments for a new patient to be established can be maybe 6 months out. Really, for our pregnant patients and our kids under 21, it's much sooner, like a couple days, couple weeks. But certainly for patients that have a more urgent concern, this will allow them to come in maybe as soon as that day or the next day, just to get evaluated for that one specific area. And so the dental clinic made blocks in the schedule to reserve space for the prenatal patients to make sure that we would have room for them. Because certainly we could have our schedules booked up in an instant. So we did need to carve out a little bit of space for the prenatal patients. And how does the prenatal provider know that the patient made it to the dentist? This is a little bit of a challenge, as Anna mentioned. Medical works out of Epic and dental works out of Dentrix. And so the dental administrative staff knows how to navigate Epic fairly well. Dental visits go into Epic as dental visits under the charges, and as I understand, the medical providers don't have a way. I don't think I, as a provider, have a way to see the charges. And so we do have the opportunity to give some people on the medical side direct access to Dentrix. So like Anna or Liz, who is the supervisor, we can give them access so they can go directly into Dentrix. You know, that's something they're going to have to make the effort to do because it's a separate login, and after a couple hours it'll kick them out. But if they so wish, they'd be able to go into Dentrix and see visit notes. And then also, again, for administrative staff, there's a way for them to review the closed referrals and see what the comments are and what the circumstances led to it being closed. We'll go later into the criteria of how we close a referral. And so, you know, at this point, it might more depend on the medical team kind of asking the patient, hey, what happened to that referral we made? Did you see the dentist? I think we can go on to next screen. So Anna can talk about the first half, which is kind of the flow chart for how the referral is entered, and then I'll talk about the second half. And I think you're muted.
I am, thank you. Just was coughing. So again, our CPSP supervisor in our program will call the patient. They do the oral health risk assessment during that visit. We also have a dot phrase that's in Epic, that's what they're called, but like a list of those questions so that she can fill out. It also helps us with our IT department pull the answers to those questions so that we can see kind of how many patients got the dental referral, how many patients were urgent referrals, and Liz will document those. And then based on the answers to those questions in terms of whether they have a dentist, whether they would like a referral, and then urgent versus routine, we place those orders. We'll talk a little bit about the education in the next piece, but Liz, after seeing if they need a referral or not, will do the oral health, a small amount of oral health education that's then followed up by the provider in a subsequent visit.
So then on the dental side, once the referral is entered into Epic as a dental prenatal referral, the clinic administrative staff reviews those referral lists a couple of times a week. They call those patients and basically let them know that we've received the referral and we're calling from the dental department and we'd like to schedule them an appointment. And if the patient agrees, then as I described, the next appointment will typically be a teledentistry, but could be directly an in-office visit if there's an urgent concern. And the clinic is holding 9 appointments a week for pregnant patients to make sure we have capacity. We can move to the next slide. So the criteria used to close a dental referral. One is we call the patient, we let them know we're calling from the dental department. We say, you know, your Dr. Catino sent you over to us as a referral. And the patient says, oh, you know, no, I have a dentist, or and this happens all the time. This is kind of the second medical dental integration that we've run. And I'm sure if you guys have done this work, or if you guys get into this work, you're going to find that just as many of us seen in the dental clinic, you know, they tell the dental assistant one thing and then the provider comes in and they have something completely different to tell the provider. So they tell the medical doctor that they don't have a dentist and we call them and they say they do have a dentist, or they tell the medical provider they don't have a dentist and we open their Dentrix chart and they're our patient and they're in the middle of a treatment plan. But anyway, so one would be that we contact the patient and they say, sorry, not interested. Another one would be once the patient has had their dental appointment. And for the purposes of this project, we said that we were going to consider it a completed referral once the patient has their exam. So as I described, they can have a telehealth, they can have an office visit to examine a concern. But for the purposes of this project, it's really about patients getting a dental exam, getting a treatment plan. So we were going to consider the referral complete once they had completed their dental exam. Also, if we try to call the patient 3 times and we don't reach them and they don't return our calls, and also if the patient no-shows to the dental appointments 3 times, and this is another thing that happens a lot, we schedule the patients for an appointment and they don't show up to the appointment. We actually have sort of a 3 strikes you're out protocol in our clinics. In our dental clinics, if a patient fails their appointment 3 times in a year's period, our protocol is that they don't get to reserve an appointment time for 1 year. So they'll still be seen. They can come in as an emergency. They can come in and sit and wait for a cancellation to occur, but we don't reserve them any more dedicated appointment slots if 3 times they had an appointment which they simply failed. And then these notes go into the work queue, and once the referral is closed, we get a report on a monthly basis from IT, and there people can see, you know, if Dr. Catino so chose, but it's a lot of work, unfortunately, but if Dr. Catino or her staff so chose to see what happened to patient Susan that I referred, they'd be able to see either in Epic the comments or in the closed report the comments as to what happened with our attempts to reach the patient, to see the patient. Next slide. And then I'll pass back to Anna.
Yeah, and just a comment on the Epic referrals. Oftentimes, like, we check on referrals for various things, and it's a little bit more challenging to see the kind of why, but we can see that the dental referral is closed or open, or that the patient actually saw the dentist, which is helpful, because I think a lot of times I will ask patients, hey, has the dental department called you? And they say no, but actually somebody has called them and they just, you know, didn't know or didn't listen to their voicemail or whatever, which I'm sure we all face when contacting patients. So I'm just going to talk a little bit about the education piece that we do. And so, you know, there's a lot of adult learning theory that say people need repetition, and talk about how often that repetition is needed to, I think, learn new information. Pregnancy is also a time with tons of information that people are taking in, especially if it's their first pregnancy. And so in one visit, you know, they might remember one salient fact of the 10 that you told them. And so talking about education throughout throughout their pregnancy is really important. So these are the different places that we do it, and then I'll talk about what we actually say. But after the risk assessment, our prenatal supervisor will do a little bit of oral health education during that orientation appointment. We have flyers and posters in the patient waiting room during provider visits with the prenatal provider, especially during the first prenatal appointment where we do the oral health exam. We try and provide education again, talking about why going to the dentist is important and why oral health is important. Once they get that visit with dental, as Monica mentioned, they'll do some risk assessment and then talk about different areas of importance during pregnancy, during the dental visit, and then during the postpartum and pediatric visits. As a family doctor, it's really nice because we get to follow people throughout their pregnancy, and so have that nice continuity, or potentially take care of other other children in the family, which can be nice. And as mentioned, the kind of areas to highlight during that are the transmission of bacteria from parents to babies or children through all of the different mentioned pathways. And so the next slide, this is kind of the basics of what we talk about that you heard a little bit earlier in the presentation, but the oral health and bacteria load in mom can affect the baby, really emphasizing, again, that there's a correlation with preterm delivery, even though causation cannot be determined, and that sometimes it can prevent babies from gaining good weight, or if you have a preterm delivery, you may have a low birth weight baby. Basics of when to call the dentist, so warning signs of, tooth pain, pus in the mouth, pain when you're brushing your teeth, pain with eating. We emphasize that x-rays are safe during pregnancy and that they don't affect the baby, and that a cover would be placed over the belly during dental visits, although the load of radiation is so incredibly small these days. For people who are needing dental procedures, that certain anesthesias are safe in pregnancy, and then it's much more important to get the procedure that you need done for your overall health, rather than being concerned about the medications that they're using to do those procedures. Like I mentioned, that bacteria can be transferred from parent to baby even before they have teeth, and so just the oral health of babies before we're even brushing is really important. And then regular dental practices: brush twice a day, flossing, fluoride, and going to the dentist. I think a lot of our patients, and probably many throughout FQHCs, we have large immigrant populations or people who have resettled in the US where they come from countries in which water is really unsafe. Tap water is really unsafe. And so many of our patients drink bottled water because they feel like that is healthier or safer, but then miss out on a lot of that fluoride benefit, especially, as children moving forward. And, flossing is not a custom that they're used to, or they brush only once a day. And so really just emphasizing what are kind of basic dental practices that people might not be familiar with is important.
I might just say, regarding the patient education, one of the things that I speak to patients, regarding their own oral health, it's fairly general information that we share with all patients. But when I do see a patient towards the end of their pregnancy, I start to talk to them about the early childhood caries and the appropriate feeding practices. So as one of the prior presenters mentioned, trying not to share saliva in such manners that she described, like chewing the food and giving it to the baby, or cleaning the pacifier and giving it back to the baby. And then also about the nighttime feeding practices and their oral hygiene practices. So I start to talk to them about wiping the baby's mouth even before they have teeth, and trying to discontinue nighttime feeding by the time the baby's 1 year old. And one thing I've really noticed is that patients seem to many be aware that it's not a good idea to bottle feed your baby at night. But the idea that breastfeeding has much the same effect, milk is milk. And so, you know, just basically reiterating that we would like to discontinue nighttime feeding by the time the baby's 1 year of age, and when the baby is fed, that the mouth should be cleaned afterwards. I really aim to have them discontinue nighttime feeding before the molars erupt, because I tell them that they can wipe the teeth with a 2x2 when it's the incisors, the front teeth, but you know, I tell them, you need to get out the toothbrush and brush their teeth every time you breastfeed them at night once they have their molars. And I tell them, you know, that's too difficult. You're not going to do it. So try to discontinue the nighttime feeding before the molars come in. Okay, we can move on to the next slide. So this is what we are using for the patient education on the medical side. The item on the left, see a dentist while you're pregnant. This is the handout, which goes into the CPSP package that is provided to the patient before that CPSP intake visit with Liz on the medical side. So in basic and general terms, it talks about the importance and safety of having dental care. And then the image on the right-hand side is a poster that we created last year with one of our UCSF dental public health residents, Richa Sinhania. This is the idea of maybe patients have issues that they're not aware of, and they think maybe their mouth is okay. And so hence on the top, you know, kind of, okay, the front looks okay when I smile, but maybe there's some issues lurking, and then show some of the examples of things that might be lurking, and encouraging them to see the dentist, with a couple little facts there about the prevalence of dental issues in pregnant patients. We can move to the next slide.
And then this is just a letter that we created for people who have an outside dentist. Obviously, with our dental integration, we feel very comfortable that, you know, the dentists that are in our office know the appropriate recommendations in pregnancy, but that's not always the case in the community. And so this is a letter that we give to anybody who has an outside dentist that just says, you know, pregnant people should receive dental prevention and treatment, including procedures during their pregnancy, that x-rays are okay, that procedures such as scaling and root canals are okay, and then what antibiotics to avoid during pregnancy. We do get a lot of questions from patients asking for a letter to clear them to go to the dentist. And so this kind of prophylactically allows us to get people into care quicker. And I think that the national consensus statement on the oral health was brought up a little bit earlier, and that's where some of this information came from, and we were able to create using our combined knowledge in dental and medical to put this letter together for other people. Monica, I don't know if there's other things you want to add about the letter.
Yeah, so basically, you know, as Anna mentioned, most of the dentists in the community health setting are familiar with treating patients, and if they've been working for any period of time in our clinic, have treated plenty of pregnant patients. But it's not always the case. And so, you know, sometimes if we interview you know, older dentists coming in from other states, dentists who did their primary training in other countries or maybe several decades ago. I had a recent local graduate just a few weeks ago interview, and when one of our questions in the interview talks about, you know, what would you tell your pregnant patient and how would you treat your pregnant patient, and this person was sort of questioning and challenging us and saying, you know, well, if you say so, do you have anything to support the fact that it's safe to be doing dental care during pregnancy? If you do, I'll consider it. Certainly there's more work to be done in that area. So again, you know, the 2012 National Consensus Statement drawn up by HRSA, the American College of Obstetricians and Gynecologists, the American Dental Association. It states basically that pregnant women are experiencing a normal biological state, and it is the standard of care to and ethically appropriate to give them the same care that you would give anybody else. And so the is, however, on some providers' part, a lack of knowledge or anecdotal concerns influencing the dental practice. But evidence-based shows that dental care is important and safe, as we've discussed here. So you do not need a medical consult to treat a patient that's in a routine pregnancy in order to proceed with routine dental care. Now, if the patient has a high-risk pregnancy, if the patient has other comorbidities, other medical conditions in addition to their pregnancy, if you're considering to do something like nitrous or general anesthesia, then you can certainly consult the patient's medical provider. But for a patient with routine pregnancy to get routine dental care, including exam, x-rays, cleanings, restorations, extractions, anesthesia, antibiotics, acetaminophen, you don't need a clearance to be able to see that patient. We can move on to the next slide.
And so we can talk a little bit about the oral health evaluation that's done by the prenatal care provider. In our experience with our grant and integration, this is probably the hardest part of what we've been doing. And just to emphasize how important it is for somebody to do, somebody outside of dental to do an oral health evaluation early in pregnancy, just because of, as Monica mentioned, in terms of the referral process, there's a lot of people who no-show their dental appointments, that you have to call multiple times to get in, and the capacity of dental. I know many of you have long delays in terms of being able to get appointments and access, and so having somebody do an additional risk stratification to identify those urgent versus non-urgent patients can be really important. In general, right, medical professionals get pretty low, if any, training in dental care and how to do an oral health dental exam, other than really looking for big plaques that could be cancer. And so a lot of the hesitancy, I think, about doing a proper oral health evaluation is just from lack of confidence due to our education. And so we had our wonderful dental colleagues come in and do an in-service at an OB staff meeting, as well as a refresher course, and kind of show us how they do a really quick dental exam, and also go through a number of pictures that kind of helped us know what we should be looking for. We also have the option to, walk upstairs and our in-house Dr. McGregor shadow her for a day and kind of see different, watch her do different exams and see different pathology that can make everybody feel a little bit more comfortable in terms of diagnosis, and use CE time for that. Combined, we also created documentation, a dot phrase, to help provoke providers to remember the different components of the oral health exam. And that was something that we tried to narrow down again to be something that's super simple, positive, negative, and used our dental colleagues to kind of identify what we should be documenting. And then other EHRs have kind of the same type of macro prompts that we've created as a dot phrase, just depending on whatever you're using as the medical EHR. So this is a reference that our dental colleagues made for us in terms of the pictures that they had shown. Essentially, what are we looking for in a healthy exam, which is noted up there. Pink, the color, consistency, texture of gums, and what concerns look like. There's some great pictures of what gingivitis and periodontitis looks like. Sorry, I can't speak. Caries, the pregnancy granuloma that we talked about earlier, to not be afraid of that as an abnormal growth. And Monica what we did is we put this in every single room, so that so as a prompt to remember to do the oral health evaluation, as a resource for doing, knowing what you're looking at doing the oral health evaluation. And because we all share different rooms, that way it's there for even people outside of this project on prenatal care, but our adult medicine colleagues who are seeing diabetics, or our pediatricians who are seeing kids, just different examples of what we're looking for.
Yeah, and I know it's normal for medical providers to feel a little concern about what is being expected of them in the nature of an oral exam. I tell people I took 1.5 years of medical school in my dental program, got the same training that the medical doctors got before they started their hospital-based rotations. And I remember pretty much one day, numbers of teeth 1 through 32, and, this is the tongue, the tonsils, and the cheeks. So I understand. And then, I just say, as a dentist, if I identify that a patient has risk for diabetes, or they have a high A1C, or I see a lesion on their face, it's my job to recognize that there's an issue and put them in contact with a medical provider. It's not my responsibility to, prescribe them insulin, to prescribe them their diabetic support. It's my job to recognize that there may be an issue and make the referral. And that's basically the situation here. So we've included pictures of normal condition, pictures of sort of mild, moderate, and severe, just so that the medical providers can say, hey, that looks unusual, send it over to us. And maybe it's something usual. As dentists, we're familiar with tori and, different things that could look concerning to the medical provider. But, I'm sure half the things we refer to medical probably maybe are not as much of a concern as we potentially thought. But if you don't refer them, it's never going to get looked into, and something important could be overlooked. So that's all we're hoping for, is sort of abnormal versus normal, and make a referral. Next slide.
And this is just a reference for you. We don't have to go into it, but since the slides will be sent out, what we're actually looking for on our oral health exam, and the pieces noted about gingivitis versus abscesses, and really just picking out the salient points in our exam. Next slide. And so our last, I believe, kind of
Domain.
Thank you. In our grant is thinking about the prevention piece, which Monica mentioned. We've chosen fluoride varnish application that's done by our medical assistants. It's not, Monica will talk a little bit more about evidence behind it, but not clear how effective this is. But after back and forth on what is the measurable and kind of most effective thing, this is what we've chosen. I do think that there's a benefit for adults in low-income settings, just because of the pieces that I mentioned about, maybe decreased brushing, not drinking tap water that has fluoridation in it. We apply this between 15 and 18 weeks of pregnancy. And we chose that because there's not a lot of things that we do during that prenatal visit other than order their anatomy ultrasound, which we talk about. So there's a little bit more time in the visit. If patients are late to care, the MA will apply at the first visit that they have. And we have created a little checklist, rooming guidelines, and added it to our rooming guidelines so that medical assistants are prompted to apply the fluoride. They have permission that if the patient says yes, they can do it while the patient's waiting for the prenatal provider, and don't need permission from the provider to wait until after the visit to apply. So it does sometimes help for flow, and then patients always feel like they're getting a service or being taken care of while they're waiting for the prenatal provider, since we are often running behind. And to do this and help medical assistants feel comfortable, we had a dental in-service again, and did a demo and practice at OB staff meetings. And we have monthly staff meetings, and so we'll do refreshers and pop quizzes. We had 2 medical assistants a couple months later do a little skit about how they applied and how they talked to patients about it. We created scripts for the medical assistants to also talk about why it's important for application with the patients, so that they could do a little bit of education again themselves. We created some of our medical assistant challenges were just, people, they didn't sign up to be dental hygienists. There was, some pushback about whether this was their role, and, not wanting to look in people's mouths because it's gross, not wanting them to take off their masks. So we worked on that a lot. And I think when you frame it as we are trying to take care of patients and their pregnancy and keep them healthy, there's a lot more buy-in, as opposed to, just adding another task to their plate that they're already overwhelmed with the things that they have to do. But as part of that, we also provided incentives for MAs to apply. And we said, whoever gets the most fluoride applications in a month gets a Starbucks gift card, until it became more of a habit for people to apply. The MA who actually didn't like Starbucks, so we got her boba tea instead, but is a good incentive to help. And then we also bill Medi-Cal for this through a procedure code that we had added to the flow sheet, which also helps people remember to apply it.
And again, we weren't able to find specific studies to show that there is a fetal benefit to fluoride varnish application. But, certainly it should help the mother. And as dentists, we know that the most important aspect of fluoride is to have it incorporated into the teeth as the teeth are being formed, and the permanent teeth are being formed at the time of birth. And so it certainly stands to reason that, it should help the baby, and it should help avoid transmission of caries to the baby. So we believe that it helps. Next slide.
And this is just a little handout we made so that patients know what they got, because oftentimes patients say yes to everything. They go home and they have no idea what's happened to them. So again, just summarizing what happened, why they had fluoride applied, how it affects their pregnancy and their baby, and then just the instructions on, don't brush or floss, leave the fluoride on, what things to eat to just make that more effective. And then everybody gets this when they leave, so that they can take it home and follow the instructions. Next slide. Oh, maybe next slide. Oh yeah. So this is, if you just go through this, Aubrey, I don't know why it's, so these are just the procedure codes that we have added, so that you can see, we put it under encounter of prophylactic administration of fluoride. This also helps us track who's gotten fluoride and who hasn't, in terms of the grant application, or if you want to see which medical assistants are doing better than others, or making sure you can create a list to make sure that if a patient got missed or missed an appointment that the MA didn't provide it that day, that you go back and offer it to them again. And in our EHR, all of the procedure codes that we enter show up in a list. So it also helps tracking and when the medical assistants are chart prepping as to whether they got it in a previous visit or not. Next slide, which I think you can skip. This is just how to sign it. And then we also found a ICD-10 code for people who have declined fluoride, which again helps just in chart prepping to make sure that we're not asking patients too many times. If a patient initially does say no to the medical assistant, the provider will go in and talk to them about it as a area for oral health education, of saying, hey, the medical assistant told me that you didn't want that. I just want to make sure that you know why we're offering it. Go through the learning points again. And then again, if the patient doesn't want it, of course, we just enter this so that we don't offer it again. Next slide.
So this is basically our project goals and our baseline. So our baseline in 2021 was essentially, and especially following the pandemic, 0 oral risk assessment, 0 oral evaluation by the primary care team. As I understand, more of the providers were looking in the mouths more before the pandemic, but then, when everybody had their mask on and they weren't supposed to remove their mask and people got more comfortable with not looking in patients' mouths, it was pretty near 0. There was 0 fluoride application being done on pregnant patients in our medical department, and pretty near 0 oral health education by the primary care team. The number of dental referrals completed prior to this project, dental did not have the training, therefore didn't have the access or the awareness to go in and look for dental referrals in Epic. Therefore, also medical department wasn't supposed to be submitting dental referrals through Epic because dental wasn't going to be looking for them. When we started this project, we found that there was a whole host of dental referrals sitting there waiting for us. And the number 57, the way we had to come up with that was basically we looked for a period of time how many pregnant patients we saw in the dental clinic, and then went back to see what portion of them came from our medical department. So it was, not a made up number, but it was kind of an indirect way of measuring what our baseline might have been. So there you can see our goals for this project. And then basically as of August 2023, we essentially have 100% oral risk assessment and oral health education, thanks to Liz, who's running the CPSP visits and has really been a champion, as well as Dr. Coutinho and the rest of the team, but really been a champion. So everybody is getting the risk assessment and the health education during those CPSP visits. Oral evaluation by the primary care team has been hard to measure. We're still trying to sort of iron out or hammer out what is going to be the standardized team agreement way to document this, and how are we going to make it something that can be pooled and reported upon by IT. So there's probably more exams being done than documented in the chart. There's probably more documented in the chart than is being picked up on sort of manual search. And so hopefully we might be greater than 9%, but this is really right now where we're focusing our efforts on before we are going to be ready to roll this out, hopefully in January, to other sites. Fluoride application by the primary care team, it's fluctuated a lot over the months. Maybe the champion medical assistants are out for a couple of weeks or something. It's fluctuated a lot over the months. I'm sure your centers, like our center, tends to be short-staffed, particularly on medical assistants, dental assistants. And so anyway, right now we're at 34%, but it still beats our goal, which we had set pretty low. And then finally, dental referrals completed. So for example, in the month of August, there's a delay. So people show up in the dental anywhere from sort of a few weeks to I even saw a year after the referral was originally submitted. I saw in September, there was a patient referred September of 2022 and April of 2023. So there's a delay, but basically, for example, in 1 month, we had 7 referrals seen in dental and 11 individuals referred out of medical. So we're at maybe about 63%. That too, there's a wide variation. And really the other issue that we're still working on in this project is this Bermuda Triangle effect that happens from the time the patient tells the medical provider that they're interested to see the dentist till the time they sit in our chair. And so, we have these appointments available. We follow up with them at least 3 times to try to get them in, but there's an attrition from the time of we call them for them to say, yes, I agreed, I want to see the dentist and I want to follow through on that, to the time that they show up to their telehealth visit, let's say, to the time that they show up and sit in the dental chair for the comprehensive exam. So, this in a sense is the crux of the whole project, is to have the medical patients seen in dental. And yet this is still kind of an enigma. You can offer the water to the horse, but we're still having difficulty in getting those drinks completed. If Anna doesn't have anything further to say on that slide, I think we can go on to the last slide. Here, what makes the referral process work well? We did find that the medical and dental teams are eager to work with each other. Again, at this site, they're housed in the same building, one upstairs, one downstairs, but they were sort of separate tracks. And so this has been a really nice part of this project. The referrals are sent and received electronically through a system shared by medical and dental, because dental can see medical's EHR. Dental went and provided several in-services with the medical department in doing the exams and doing the fluoride varnish and answering questions. And again, at this site, medical and dental are co-located. We do have other medical dental integrations at other sites, some of which are not co-located. Essentially what we've done there is we kind of pair co-located sites for referrals, and then where we have a medical site and dental sites that are not co-located but more geographically close, we pair them for referrals. And also what we found, like my clinic is about 6 blocks away from a co-located medical and dental clinic. And so if we tried to refer patients from the co-located clinic over to my clinic, they all would just assume, despite being told, that their appointment was downstairs, and they'd inevitably show up at the wrong dental clinic. So this too is a reason for which we kind of pair co-located sites for referrals and then pair non-co-located sites for referrals. Some of the challenges, so again, the medical team can't really see dental's notes or schedule unless we give them login to Dentrix, which we can do. But again, you know, it's a separate login and it takes a couple of minutes to get into it to try to find the information. There's not really a mechanism for dental to respond to the medical provider with quick concerns such as chats, again, because as a dentist, I can go into Epic and I can see the medical notes, but that was basically the extent of our training on that. I do believe there is a chat feature, but dental only goes into Epic. The dental providers go into Epic when they want to specifically find something about that patient's health or write a prescription. I go into Epic maybe once every week or two. And so those chats wouldn't be seen. We do, however, have a company directory, and we can reach out to each other by email. Again, medical assistants questioned their role in oral health and having anything to do with the mouth. Medical assistants were a bit reluctant to apply fluoride varnish, again, questioning the benefit to patients, questioning their role as oral health providers, and then just this sort of reticence after the pandemic to be that close to the oral cavity. And then the PCP buy-in and the completion rate of the oral exam, or getting the oral exam done and getting it documented in a way that we can measure. So I think that's it. I know we're almost at time. There was a few more questions that had come in by the survey, but I think we've mostly covered them. And I know there's been questions that have come in during the presentation. I don't know if anybody's been monitoring to kind of see what are the most common or important questions that have come in.
Yeah, thank you both so much. I just want to start by huge gratitude for you to present all of the amazing work that you've been doing and sharing this with our team here today. It's amazing. You're getting a lot of kudos in the chat as well. Some of the questions that came through the chat have already been answered. So if you asked a question, scroll through there and check. I know something that came up through the registration is like that question of buy-in, which you just touched on, and like how do you actually get that buy-in from the medical side or even from the dental side to make this work together. And I know a couple of other counties have been working in this area too, and if they want to chime in as well, but Dr. Coutinho and Dr. McBean-Pearson, if you have any thoughts on that in particular, I think that would be great.
I can say for the dental department, it's probably pretty quick. From the time we interview people, it is one of our interview questions, one of our clinical scenarios that we interview on. Also like seeing kids. And so if I have somebody in the interview that expresses that they're unfamiliar or uncomfortable with seeing pregnant patients or little kids, I let them know that 50% of our patient population is under 14 years of age and that we have a lot of pregnant patients. And if that's going to be an issue for them, then it may not be the best match for them. So that's that's the buy-in on the dental side. As I say, those that have worked here for any period of time, we've already seen lots of pregnant patients coming through our doors. So that's the buy-in on my side. It's screening those providers out before they become my employee.
Yeah, that's
And
fair.
I would say on the medical side, right, we all want to do what's best for the patient. And I think really using patient outcomes and patient benefit as the buy-in and coming up with, I think, workflows that make providers feel confident and minimize their workload, right? Where I think the biggest piece about buy-in is like, I have to add another thing to my long list of things to do, which is everybody. And so as much as we could, we tried to kind of create supports for providers, minimize the impact on the actual visit. So putting a lot of that work on the medical assistants who are unfortunately also very stressed, but, you know, taking out the risk assessment and putting it with a different person. You could just use a medical assistant, right? You don't need to have a whole special visit like we did. Having you know, the fluoride application be done by the medical assistant and that they can do it without the provider permission, having somebody else be placing the referrals, just to minimize, I think, impact on the actual provider, because that is where the buy-in piece usually gets held up, is like the actual work.
Yeah, I'm seeing a couple questions. Raise hands. Hayam, go ahead.
Thank you, Aubrey, for the opportunity. Yeah, I wanted to thank you for sharing the success story of your program and having this as a model for other public health departments to implement as well. I wanted also to share our experience that I feel it is successful so far. We're still in the beginning, but it is successful that we are having this integration is a non-co-located. So we receive referrals from CPSP coordinators, and this is how it happened, is like we reach out. We have a care coordination program that's well established, and we have this communication with so many organizations and programs. One of them is the CPSP. They used to refer to us pregnant women and postpartum, and now it is like when they know that we are focusing on this population, they are referring to us more and more. And our care coordination, they connect the patient, we contact the patient, educate them again, and reinforce the messages, and then connect them with the dentist and follow up with attending the appointment. So this is another model of non-co-located, but thank you.
Thanks so much for sharing. I appreciate it. And there's another hand raised, Adiam.
Yes, thank you so much for the great presentation. So the question I asked about the data by race and ethnicity was also related, and I see your answer about the MIHA data, and thank you for that. But it was also related on the observation study that you mentioned earlier. There was a positive association. Now I don't remember the exact specifics in relation to the African American community. And so my question is, in the study, was there was there a further step done to know as to why that was? Just curious, you know, we have a lot of factors, whether it's implicit bias or social determinants of health, so I was curious as to why the association. Thank you.
Sure, I can take that real quick. Thanks for the really good question about that, about the body of research that had that outcome. I don't know specifically of each of those studies. It's a review of the literature, but what I can do is I can follow up and send you the references of those studies if you're interested in looking deeper.
Yes, thank you.
All right, everyone, we are already 2 minutes over our allotted time, which went so fast, and we pivoted. We wanted to open up breakout rooms to allow some discussion, but I didn't want to interrupt our presenters today. So I just want to stop here and say that we will capture questions and we can follow up in an email with some of those answers that you and the wonderful questions that you asked. So big round of applause for everyone who presented today. We super appreciate it. I dropped our evaluation link in the chat. So if you have a moment, please give us some feedback. We appreciate it. And thank you all for being here and for your engagement.